keeping with the theme of traveling through the lungs, we are going to finish it out today with the interstitium of the lungs, which is the kind of that fiber framework between the actual organs, which are the alveoli. So there's a framework, the structure of the lungs, that's what we call the interstitial, the non-organ part. We'll talk about diseases in that area, and then we're going to round it out by talking about disease in the pulmonary vasculature. And that should get us through the conducting portion, the parenchymal portion, the interstitium, the vasculature, the pleura. So we've kind of rounded all that out. All right, so 15 slides. This is a pants topic. So again, is it high yield? Probably not, unless you're working in pulmonary specialty. But again, the only diagnoses we'll always miss are the one we don't know about. So being aware that diseases can occur in that interstitium. That word pulmonary fibrosis that we talked about in the occupational exposure lecture, essentially what we discussed is that it's a scarring of the lung, usually from repeated inflammation. So similar to scarring on your skin, you keep picking at a scab over and over again and you don't just let it heal, right? The fibrosis changes, the healing process can sometimes replace normal tissue with fibrous things. Oh, you haven't learned term yet. I won't confuse you. Okay. So this is a definition. This is an umbrella term. Interstitial lung disease is talking about a certain part of the body, a certain part of the lungs. There are tons of different causes. We'll talk about some of those. The most common cause of this is we don't know what caused it. So remember that word, idiopathic. We don't know what caused it. Diffuse involvement involves the entire lung. Again, interstitium is throughout the entire lung. That's what the framework of the lung is. So it's going to be diffuse. Some sort of inflammatory changes that lead to fibrosis. Interstitial lung disease, we talk about specifically in the interstitium, but because it's so closely approximated to the alveoli, the parenchyma of the lungs, it really involves both. So it doesn't just get to the alveoli and stop, right? That fibrosis, those fibrotic changes that change normal tissue don't just stop when they reach the border of the alveoli. So it's going to affect a lot of that respiratory zone of that lung exchange, including those terminal bronchioles. But it does not affect the large airways. So check on learning. What type of PFTs, restrictive or obstructive? Restrictive. Okay. All right. So pathophysiology, again, some known or unknown, more commonly, injury to the lung. Body attempts to repair itself. So when we biopsy these patients, it shows a similar reaction of the body trying to repair itself. That fibrotic changes, and it leads to fibrosis, which is permanent. It affects diffusely in the lung, so it doesn't just go to one particular area. Apex, lower lobes, it involves all of them. We'll talk about this term honeycombing, which is a radiology term because of how those changes appear on imaging. We'll show you what that looks like. And the main complication of this is you lose the function of the lung, which is to exchange gas. It impairs respiratory gas exchange and leads to death. All right, so just some pictures. And this is a representation of normal alveoli. That's the interstitium, that structural area between the alveoli. And then it's replaced by this fibrosis. So you lose that functional part of the lung. No specific etiology can be found in most patients. You want to try and find it, because if it's something you can avoid, then you want to do that. Some known causes, right? Some medications can do this. Sometimes some of our occupational diseases can cause this. So being able to identify it, or at least try to identify it, this is what our specialists will do. Once we have identified that the patient has interstitial lung disease, the next game is to figure out if there's something that we can do to stop the progression. But again, in most times we don't know what causes it, so we don't know what to stop exposure to. So making sure you get a good history. There is a very strong correlation with autoimmune disease. We're going to talk about scleroderma. Or not scleroderma, sarcoidosis, so totally different, I guess. We're not going to go into these in this lecture, but autoimmune disorders can do it. And this sometimes can be one of the clues, the clinical clues, that someone has an underlying autoimmune disorder. And this may be the first manifestation of that. It may present with respiratory symptoms. So dyspnea, this is going to be the main one. It's not going to be necessarily wheezing. There's not going to be, but the shortness of breath, that's what patients are really going to come in complaining of. So you have to get kind of a full picture of what this patient's about, including their occupational exposures. Sometimes dry cough, it's going to be one of those chronic cough situations. Sometimes if it's progressed enough, you can start to hear some of those abnormal alveoli in the form of crackles. And then their resting SpO2 may be normal. It's kind of like angina, right? So at rest, there may be enough gas exchange for that patient to be okay. But the second they get up and start doing activity, we unveil that problem. So cardiac chest pain, you've got blockages. Patients can be fine when they're sitting there. As soon as they start activity, they get that anginal pain, right? And then when they stop, it improves. This is very similar. So activity will unmask this and show the deficiency of that respiration portion of the lung. Chest x-ray is variable depending on what stage they're at. We'll talk about this ground glass appearance. So if you imagine you break up some glass and you spread it all over, those little shards of glass, those represent the abnormal fibrous tissue. So it's going to be throughout the lung fields, but to take on, it's not going to be like diffuse consolidations like we see in viral. They're going to have like little sharp edges to them. Oh, I'm blowing up. Sorry. Sorry, I can't focus. All right. I'm not in that multitasking phase. All right, so then we'll talk about what this honeycombing is. And again, it's a representation on CT, and I'll show you what that looks like and how that correlates to what we showed back here, which is what happens to the terminal bronchioles, alveoli, and interstitium when they are replaced with fibrotic tissue. Mixed pattern, FVC. This ratio, right? So we're going to have a normal FEV1 FVC, but then that FVC is going to be decreased. I put this on here. I'll talk about it in the review. Sometimes I give them another. That's one of my jerk questions to reward the people that are like. Sometimes I'll give them. You guys be like, oh, I know this is restricted, and then I'll be like, oh, you forgot to notice that they also had COPD, right? So keep that one in mind. I'll hit it again at the review if I think it's going to be something I want you looking out for. That's definitely, so whenever I put that question in there, I'll have people come over and say, ma'am, and I'll go, we missed the COPD, and then I'll be like, yeah. All right, so keep that in mind, and then make the tissue biopsy is going to be a definitive diagnosis for this. So specialty care, once it's identified, patients with interstitial lung disease should have seen or continue to be seeing a pulmonary specialist. These are all possible causes. Look up here, FYI. We are going to talk about sarcoidosis, and we are going to talk about the most common type of interstitial lung disease, which is idiopathic. But if you look here, there's all kinds of other reasons. Here's our hypersensitivity pneumonitis. These are our fumes. We've got some connective tissue diseases down here. So these are the things that essentially we want to try to rule out, because if you can treat these or you can avoid them, then we can stop the progression of this, and patients can maintain respiratory function for a little bit longer. All right, this is that ground glass appearance. So what differentiates it from kind of that diffuse, what do we call it, with viral, diffuse densities, or we say lobar versus diffuse, is that they look a little bit more sharp on the edges. I know I say that, and I'm like, do they really? But they do. This is, again, why radiologists get paid the big bucks. But it just looks a little bit more sharp on the edges. And you can go in there and find certain places where it definitely looks like sharp edges of the, this is all fibrotic tissue. This isn't inflammation from a viral illness. These are all fibrotic changes to that parenchyma of the lungs and the interstitium. And we'll talk about these a little bit more on the next slide. All right. When we talk about honeycombing, we'll talk a little bit more about that, because this one on the right relates a little bit more to honeycombing. All right, so the idiopathic. Again, idiopathic means we don't know why the person has it. We've gotten a good history, we've done maybe some genetic testing, we've done a biopsy, and all we know is that there's fibrotic changes. It's a restrictive finding on a PFT, and the patient gets diagnosed with interstitial lung disease. We don't know why. It's the most common subtype. The other ones, again, we talked about the other causes. These are the signs and symptoms. Again, they're exactly the same. I just copied that box forward. These patients are going to be predominantly dyspneic on exertion, especially. They will very quickly desat when you try to get them up and walking around. Restricted pattern, we'll go over this honeycombing in a little more detail, tissue biopsy. So exactly the same as the bigger term interstitial lung disease. There's really no differentiation other than we looked for a cause and we couldn't find it, period. At any point in someone's treatment for interstitial lung disease, or when they're diagnosed with idiopathic, at any point they can transition to, oh, now we know why, right, during that workup. We've identified a cause, it's treatable, hallelujah, or we can initiate avoidance so it won't progress. But most commonly, we never find that cause. So this is certainly a referral, as we would expect, since this is a immune response to inflammation, where we're causing fibrotic changes. The steroids are gonna be useful. So very commonly used in this guys.
Do you need to have tissue biopsy?
Yeah. I mean, I'm not a pulmonologist, but I would say that. In most cases, you want to do a confirmation, because there's really no other way to do it. It can be super highly suggested, like it's obvious, but especially if you want to use these, most insurance companies are going to want confirmatory diagnosis. So. Now, if they're waiting for biopsy, obviously, and they're symptomatic, there's no need to wait to start them on treatment, especially if we're just putting them on steroids. And then there is lung transplant, very limited benefit. Lung transplant is one of those. It's getting better. There's less morbidity and mortality associated, but it's still one of the newer transplants. So we're still getting there. This is not, oh, you can just get a transplant. Oh, you can just get a knee replacement. This one's still coming up. So the earlier we can catch this, God forbid, the earlier we can find out it exists, get them off the medication, get them out of the toxic Q environment, because at a certain point, mortality is extremely high. So average survival, even when we figure out what's going on, for these ones where we don't know what's causing it, so we can't stop the progression, about 2 to 5 years. It's not one of the good ones to get. All right, sarcoidosis. Again, this was one of our underlying causes of interstitial lung disease. This is the second most common. This is the classic patient. So for spontaneous primary pneumothorax, our classic patient is a 24-year-old male who's tall, who smokes, and maybe has some Marfan's characteristics. For sarcoidosis, it's typically a 20 to 30-year-old woman with African American descent. So there is ethnic predisposition, usually occurs in young females, but when I show you the picture at the end, you will see that it crosses all genders, It crosses genders, and it crosses ethnicities. Let me get into politics real quick. All right, so So granulomatous, remember we heard that word? Granulomas, we talked about that in TB. So granulomas, so it's a word that we use to describe a specific immune response to things. In the lungs, it can be in any part of the body, but granulomas, granulomatous diseases are diseases that stimulate this immune response in the body. Granulomas form. And again, they can occur really in any organ, but most cases of sarcoidosis have lung involvement. This is where you're going to see it. Symptoms. So this is one where the presentation can be highly variable. A lot of patients really have that non-specific. This is like early mycotic pneumonia, right? Their body's just mounting some immune response. They don't feel good, they've got malaise. They usually don't complain about losing weight, but you know, they're just tired, they just don't feel good, they have like a weird cough. So really, most people, for an otherwise healthy 20 to 30-year-old female, are going to probably say, oh, you probably have a virus, right? So very nonspecific. And if you look here, only about 15 to 20% even become symptomatic. So again, similar to that mycotic pneumonia, that's just how it presents. Most patients, especially if they tend to minimize symptoms, a lot of them won't even present for this. There's these two skin findings. They're not significantly common, but knowing that they exist, knowing what they look like, God forbid the patient has them, you should probably be able to correlate that back to, you know, that this is probably needs to make me think of sarcoidosis. It is not unique to, obviously, erythema nodosum is certainly not unique to sarcoidosis, but being able to know that when you see this, the sarcoidosis could potentially be in your differential. So you see erythema nodosum, and then you go to Google and you put what can cause erythema nodosum, right? And then you come up with a differential, and then you go present to your attending. All right. This other one, I'll show you a picture of that. This is just a very rare, but again, something that if you don't know it exists, you won't be able to correlate it. You say, that does not look normal. Right? You take a picture of it, and you send it to Google. It tells you what it is. I'm kidding. Not really. All right. Do what you got to do. And by Google, I mean your preceptor or your supervising, or what do we call them now? Collaborating physician. Now we're collaborating physicians. All right, so so lung exams typically normal. You may see some other clues on exam. Again, not extremely common. Most commonly, patients don't even know this is going on. Labs are not really diagnostic, but they can help eliminate other things. Maybe you get a CBC to look for neutrophil count. But again, not extremely useful. The bilateral hilar lymphadenopathy, again, this is usually what it comes out looking like. This is how the body's immune system reacts to this process going on in the body. So this is something that you may see. And then, of course, the granulomas. It affects the parenchyma of the lungs, not the airway. So restricted patterns common with this. And then this is where we differentiate between granulomas, say, in tuberculosis versus granulomas in sarcoidosis. You do not have that central necrosis. Non-caseating. Caseating, every time I think of caseating, I think just like an abscess. So there's bacteria and there's purulent material in there. You can see that on biopsy. So that these are non-caseating. This is not associated with something that would create purulent material as a result. Versus these ones, TB and other fungal infections could be more the caseating. This is FYI. This is your erythema nodosum. All right. See this, and you're like, man, this person falls down a lot, right? That's what my shins looked like when I was a kid, just because I was a tomboy. But that is, again, this will be something that you cover in derm a little more detail. This is that lupus pernio. That is very uncommon, but you get those changes on the skin. And then again, this is a systemic issue. Most commonly, it'll present with respiratory symptoms. But you can have arthritis from it. So again, this affects the body. This is where we see our skin changes. So this is FYI. All right, so these two, I hate teaching subtypes, but I've seen them a couple times on the pants, so I want to make sure that you're aware that they exist. These are people's names, which again I hate as well, but they seem to be useful test questions, so I'm going to keep teaching this until this stops being a disease, right? So Lofgren's, the thing that's interesting about Lofgren's is that if a patient has these three symptoms, it is 95% diagnostic. That's awesome. So just based off of a chest x-ray, a physical exam, and symptoms, that has a 95% specificity for Lofgren's. So that's just something, again, when you get ready to take my test, those are your last little tidbits that you're going to shove in your brain. Piriforts, I have a little picture of that. Again, this is another one where we've got, this is a syndrome where we've got these things present. So someone has a fever, they've got uveitis, and their parotid glands are swollen without a facial nerve palsy. That is considered a clinical diagnosis for Piriform. How do you treat it? You refer them. If you suspect this, you can make a phone call first, but in general, this is probably a referral. Not something that we typically, especially when you're talking about using oral steroids, especially if you're talking about using oral steroids for months to years, I recommend that you involve specialty care, not only to take that responsibility off of you, but there is a lot more time and a lot more resources that specialists have to monitor patients, to make sure that they understood that what directions were that you told them, to give them phone calls, to make sure if they see other specialists, they're coordinating that. So it's not necessarily that an internal med doc is smarter than you, it's just that they have more resources and more experience to kind of do the little subtle differences and changes and make sure patients get taken care of. All right, so the best news, most resolve after 1 to 2 years. So patients may never even know that they had it. They may have been asymptomatic. They may get a chest x-ray for something totally unrelated in their 50s, and somebody's like, well, you have these granulomas, right? So the remainder of them will go on to have chronic disease. So it is a diagnosis that we should be able to identify early because we can use medications to help treat it and not get into that chronic disease state. Okay. I'm just going to keep going. The PEs are next. So we're talking about the vasculature. That'll be the last one we talk about. Until we see you after Thanksgiving. Am I totally on showing you guys all my secrets here? So the PEs. You probably already learned about these somewhere. All right. So go back to, I think I stole this from A&P lecture, I forget. But here we're talking about pulmonary vasculature. Pulmonary vasculature is where the pulmonary artery is carrying deoxygenated blood to the lungs. And the pulmonary vein, right, so this is the artery, and then the pulmonary vein is bringing oxygenated bright red blood back to the heart on the left side, so we can pump it out to the body. So we're between the heart and the lungs. So we can imagine if there was a disruption in that process, right? there's a disruption in getting the blood from the heart, right side of the heart, to the lungs. You start thinking about how that could affect the body in general. So obviously, if we're not getting the blood there to the parenchyma to exchange and pick up, we're going to have dyspnea, right? So we're going to have maybe some hypoxia, depending on how big it is. The other thing is that when you have a stroke or when you have a heart attack, when there's any sort of blockage or plug in that blood flow, and that distal blood is not only going there to pick up oxygen, but it's also, there's also vessels that are feeding the organ itself blood. And so when we cause organs to be ischemic, we have pain. So shortness of breath, pain. Also, if we're not able to move that blood, right? The heart's getting the signal that we're not able to move that blood, or the pulse ox is dropping, then you're going to have a heartbeat that's going to try to beat faster to make up for that. So tachycardia. And then when the body perceives it's short of breath, it's going to try to breathe faster to exchange more air, and so it's arrhythmia. So those are going to be the common things that we're going to see when we talk about pulmonary embolism. And at the end, we're going to talk about a specific topic, pulmonary hypertension, and cor pulmonale, and then the last two are going to be just little topics that are specific examples of what we call pulmonary vasculitis, which is inflammation of the pulmonary vessels. If you guys have to go and pee too, I won't. No harm, no foul. All right, PEs, I like definitions, because sometimes I panic when I hear a word, and if I understand what the word means, then it brings me back to something intelligible in my brain. So embolus means a wedge or a plug in Greek. And so embolism means a wedge or plug in a blood vessel. A pulmonary embolism is when it occurs in the pulmonary artery. So, third leading cause of death in hospitalized patients. In most cases, in fact, when we talk about building our screening tools, a lot of these screening tools are grouped around establishing what a patient's risk for a deep vein thrombosis is, so a DVT. So a lot of the criteria that we use to estimate someone's risk of having a pulmonary embolism are related to their risk of having a DVT. It doesn't mean that DVTs are the only thing that cause emboli in the pulmonary vessels. Because you have to imagine when that thing shoots off from wherever, whether it's a piece of, a piece of a tumor, whether it's a piece of a fungal infection, when that shoots off, the first time it is coming up, the first time it's passing through the heart, it's coming back in the IVC, going into the right atrium, goes down to the right ventricle. So the first time that wedge or plug meets a descending diameter, right, the first time is when it's probably getting into that pulmonary vasculature. And sometimes it's like when a carotid valve plaque breaks off and it goes up to the brain. So it's going to try to circulate through the brain vasculature, and at some point it's going to reach something that's too small of a diameter and it's going to stop. That means everything distal to it is not going to receive oxygenated blood and will become ischemic. So depending on how big that thing is, makes its way through the ventricles of the heart. Now the biggest and the most concerning is when it wedges itself right in, that's called a saddle emboli. We'll talk about that. So it's big enough to make it through the ventricle and the atrium on the right side of the heart. Atrium and ventricle on the right side of the heart. But as soon as it starts to decrease in diameter, right? As soon as it starts to decrease in diameter, right where that artery breaks off to right and left, now it's too big to get down into these smaller arteries, and it'll block off. And that means that that whole lung is not getting perfusion. So these symptoms and what people present with are going to be very dependent on how big that emboli is. All right. Again, most of them are asymptomatic. So a lot of them, they happen more commonly than we think that they do. So the asymptomatic ones are the ones that are small enough Because again, if you look at the lungs, we've got all this redundant organ, which is wonderful, right? We have little backups. So if you drop a lung, you're not going to die because you've got another lung. And then even within each lung, you've got kind of redundancy built in, because respiration and oxygenation are right up there with most critical life support functions in our body. So these ones are probably really, really, really small, made their way all the way out into one of the peripheral arteries, didn't really cause any symptoms. Ew, this last one always freaks me out too. I hate that word. Alright, so we'll talk real quick about DVTs. I know you guys have learned about this, or you will go over this again when you talk, when you do HEMOC. We have this thing called Virchow triad. I don't know if you've been introduced to that yet. I'm sure Commander DeBoer talked about this, because he talks about vascular disease, right? Okay. Yep, I think I actually sat in this. I had a lecture on this. So this may look a little different than his, but in general, what we're looking at is, does this person have any reason where they're, and this again, we're talking about thrombus formation, so the body's likelihood, risk factors for forming a thrombus, forming a blood clot, basically. So hypercoagulability, so there's something going on systemically in the body, or within that hematologic system, where the blood just coagulates a lot easier. That's our little Rottweiler that we lost. He had a PE, we were treating for cancer. So we took his leg off, and he was doing great, and then about a year later, you know, he was sitting there doing his little tripoding, trying to breathe. And you know, you're in denial, right? But in reality, he had cancer. Taking his leg off, we didn't do the chemo. And so when we didn't do an autopsy, but it was pretty clear that he had thrown a PE. So that's his little memoriam. Pregnancy, right? That's a risk factor. You start having a baby, you get pretty, you want to have that for your own safety, right? Your body wants to be a little bit more hypercoagulable, because this can be a very potentially blood-losing situation when you give birth. All right, and vessel wall injury, this is where our post-op patients come in. So our ortho post-op, probably the most DVTs I ever treated was when I was on inpatient. And ortho would consult us a lot for their patients. That's why we need to make sure that we're treating their pain, so these patients get up and walk around as much as they can early on. And then we got those little squeezers on their lower extremities. This is what we're trying to prevent, because as they're healing, they're more prone to develop thrombus. And then the classic, right, airplane ride. That's the classic, you know, so-and-so was on a 16-hour plane ride, and you're supposed to be like, oh, that means they were immobile. So, immobility, for whatever reason, either the patient was immobile, or there's some other reason that the blood is not able to circulate effectively. All right. So when this piece of this clot breaks off, there's some physiologic effects. So in addition to simply blocking it, the other physiologic effects that make this worse is that it actually can trigger a vasoconstriction in that vessel and cause increases in pulmonary vascular resistance. So not only does it obstruct, but then you've got some vasoconstriction around that, which makes it even worse, and then it increases that resistance. And that resistance then is translated back to that right side of that heart. Which in some cases, if that emboli is big enough, and it maybe, like I said, our saddle emboli, then that resistance back on the heart can actually put someone into right heart failure acutely if the emboli is big enough. Alright, let's see, anything else on here? Oh, and I just said that. So when they're really big, we're talking about ventricular failure, leading cause of death in acute patients in this situation. But in this course, we're not going to really get into that. EMED will go into that for you. All right, so this is called a VQ mismatch. And this is a concept, I have to look at this over and over again. It's very simple once you figure it out. And then the V stands for perfusion, or excuse me, ventilation, and the Q stands for perfusion. So ventilation is the blue, and perfusion is the red. When we talk about diagnosing these, we're going to talk about something called a VQ scan, which is exactly that. One part of the test measures ventilation, one part of the test measures perfusion, and then they overlap them to decide if and where pulmonary emboli is present in the pulmonary vasculature. So you've got, usually it's a normal 1-to-1, right? So air goes in, oh, this is the left side, right? Air goes in, half goes to the right lung, half goes to the left lung. Blood goes in, half goes to the left lung, half goes to the right one. It's nice and beautiful, and it matches itself. Now, to have a mismatch, that means that the ventilation didn't change, but now the perfusion has changed. And what happens is, because this perfusion has changed, unfortunately, what the body will do is it will actually shunt more inhaled air to that lung that's not as well perfused. So it almost makes the problem worse, based off the body's physiologic response to now this part of the lung only receiving a fraction of the perfusion. And so all the blood is over here waiting for the oxygen, but our body's shunting all the oxygen to the lung that's not being perfused. So, all right, clinical features and labs. So patient history. So there's another one. Let's see, we got Light's criteria. We got Wells. Now we have Wells criteria. We got our curve 65, right? So this is going to be our Wells criteria. Did Commander Board go over this? So you feel comfortable, right? We'll just kind of go over it briefly. It's based on Virchow's, just like we said. Right? So questions that we can ask you. History questions that are important. So if you're considering pulmonary emboli in your differential, you want to make sure that we ask about those. Now, in my ClinCor case, because we hadn't gone over this, I think I told him, like, oh, your D-dimer is negative, so that ruled that out, right? But in general, if you're thinking that, you should go through a more specified history, right? Have you ever had a blood clot? You're like, well, what does that mean? Well, I'm thinking PE, so that's an important part for me to do the clinical assessment for possible PE. Whether or not they're on, so this would, whether or not, what meds they're taking, right? What their past medical history is. Recent surgeries, right? All this stuff that we learned in med history, this is where this stuff starts to come into play. Why do we ask this question? And slowly but surely, when you're on the other side, it'll start to make sense. And then you'll understand what pertinent means. Pertinent means, if it's not in the differential, it's not pertinent. And if it's pertinent and it's not your differential, it should be in your differential, right? So, that's how that rule goes. All right. So this is our triad, like we said. So they're going to be short of breath. They're going to have chest pain, especially when they're trying to take those deep inhalations. And they're going to probably be breathing a little faster. Tachypnea, tachypnea is usually the most reliable sign. So respiratory rate for your test questions, for your OSCEs, the patient will be tachypnic over 30. In real life, you know, sometimes you'll have to get the D-dimer, right? But it's very reliable. So if a person comes in and they say, what's the respiratory rate, and it's 16, doesn't mean they're not having a PE, doesn't mean you don't have to go in and assess for it, but it should be reassuring. It should be, when you're making your clinical decision making and you're saying why you don't think it's a PE, you can say, patient is eupnic, right? Their respiratory rate is 14. That is part of your clinical decision making of why you're not sending this person to the emergency room, right? But a respiratory rate of 32, that's 1 point up. That means on your little moving A to B differential, now maybe we've just moved PE up a little bit. It gets an extra point. It's very reliable. Most patients will have a respiratory rate over 20. In most cases, it's probably going to be closer to 30. For test questions, I'll make it over 30. All right, and then the rest of them. All right, we talked about tachycardia, maybe a little cough, right? It's down in the vasculature, so maybe we have a little hemoptysis going on there. Pain on inspiration, pretty common, up to 74% of patients, and then shortness of breath. So the most reliable sign is a objective finding, so that's nice. It's a vital sign. Just remember that patients can get nervous, and that can cause them to breathe fast as well, or if they're in pain. All right, exam's not going to be huge, especially if it's a smaller PE. You may hear some changes in that parenchyma distal to that obstruction, where those alveoli are not being perfused. You have less oxygen there, so maybe you're not opening up those alveoli. So when you have to take deep breaths, you may hear crackles. And then obviously you need to make sure you're examining these patients for any signs of DVT. Not just in the lower extremities. You can get DVTs up in your axillaries too, so make sure you're looking for signs of DVT and asking the questions. All right, D-dimer. The D-dimer, that's going to be, in most cases, when patients come into the ER and you have a patient with chest pain and a tachypneic and you have DVT or you have PE on your differential, D-dimer is going to be the test, right? If you think they're in a CHF exacerbation, you order BNP. If you think they're having an MI, you order a troponin. So D-dimer is a protein that your body makes to help break down clots. So it would follow, unless the emboli is not a blood clot, which is most commonly a blood clot, but it would go with that if you have a clot in your body's going to make more of this protein. So that's how we use the D-dimer. And D-dimer doesn't necessarily make the diagnosis. We'll talk about this on the next slide. It just tells you, it's like a screening test, right? This is the nice part about it. It's a great rule out test. So if you get it, you can exhale. If you get it and say, I ruled out PE as a possible diagnosis because of negative D-dimer, that's a good thing, right? Because it's very reliable to rule out. But there's a lot of false positives. So it doesn't diagnose the PE, but it says maybe they have a PE. We have to go further. All right? And then again, we talked about troponin and BNP. Those are usually D-dimer, troponin, BNP. D-dimer, sometimes CKMB, right? We used to do that a lot. But that's going to be, especially on your ClinCor cases, these three are always grouped together. Because it's like CHF exacerbation, PE, and MI, done. Or oh crap, right? They're positive. And then ABGs, if you get ABGs on these patients, all right? So we're going to usually see a respiratory alkalosis. So got some air trapping in there because we're shunting too much air into one lung. We are not ventilating effectively, but it can vary. So this is not going to be one of our strong. This is going to be the big. This is going to be the big guy. Now this is interesting, right? So 70% on EKG, 70% of patients have sinus tach. That is usually the only thing that you're going to see on these patients. That is the most common finding. When you get an EKG on a patient with PE and it says sinus tach, that is consistent with PE. And I told you back here, the tachycardia was only seen in about 44% of patients with PE. And the reason that this number is high is because it's a different subset of patients. These are patients that are symptomatic enough to have sought care. So it's a different denominator. So 70% of patients that present such that the clinicians have decided they require an EKG, that's why this percentage is a little bit bigger. Just in case I have any nerds in here that, like, oh, holy, you said only this many percentage. This is a different subset of patients. These are ones that actually present to an ER and have an EKG done. All right, and then these other two things, the McGinn white sign, I'm not going to test you on it, but it's one of those things that you know, when you're studying for your boards, and there's those little like cheat sheet things, the McGinn White's probably gonna be one that they list under PE as a possible test question, clue, but it's not gonna be the only one. Most likely, the patient is going to have sinus tach if they have a PE that's significant enough to give them symptoms. All right, that's a picture, it's FYI. Imaging special studies. Chest x-ray is rarely diagnostic. In fact, I would say it's probably not diagnostic, but it's usually part of the intake when patients are coming in with shortness of breath, chest pain, right? What else are you ruling out? A pneumonia. So the CTPA, this will be the study of choice for PE. And I'll show you when to order that. Not for everybody to come in, but it's patients where you reasonably, clinically suspect they're having a PE. Having a PE. Have a PE. They're not having a PE. Well, they're happy to have a PE. Right. And then a lot of times, sometimes you'll just hear it referred to CTA, which is fine. Just don't get confused. Both terms mean the same thing. It means a CT, right? We know what that is, but we're also adding angiography so we can look at the vasculature as well. This VQ scan, we're bringing that one back out, and this is an alternate. I know that I've seen a slide on this before. I will reiterate who this is for, or who you need to consider this for. Then we've got another study that will be frequently involved in the workups, which is our venous ultrasound. So anyone that we suspect with a PE, usually they're going to get, especially if they have findings, right? Tenderness in the popliteal area or anywhere along that deep vein line, either in the lower leg, up in the upper leg, or sometimes even up in the upper extremity. And then rarely performed, so we'll see. All right, chest x-ray, again, not diagnostic. But again, this is a test question. I'm not going to probably ask you, not probably, I don't ask test questions on this in Pulm, but I have these in my slides because we still use these as clues and test questions. It will not be the only clue, but if this happens to pop in your brain while you're taking your boards and it helps you get from, I think it's one of these two, to, oh crap, Hampton's hump, you know? I remember that was definitely PE. And so what, I'll show you what these look like. So this one's a wedge-shaped opacity. It represents basically a hemorrhage right past that emboli. And then this watermark sign, so that means it was big enough to cause damage to that pulmonary artery, and it's caused bleeding in that artery. And so you'll see that hemorrhage distal to that emboli, to that PE. And then the Westermark, this is a, it's kind of like, it's a prominence of the vasculature. So usually it's hard to visualize, but when we have that process where the vasculature has that reaction, that physiologic reaction to that emboli where it becomes inflamed and it constricts, we can sometimes see that on imaging. So there's our Hampton's hump, right? So this is an area of hemorrhage. So the emboli is probably right here in that middle right lobe. And then distal to it, we can see bleeding into the parenchyma of the lungs. And then the Westermarks, this one's a little bit harder to see, but it's the prominence of the dilated vasculature. So when you can imagine that plugs in there, everything is going to be not swollen, but inflamed, and it's going to have inflammation such that you can see that show up. This one's a hard one to see. Wait, let me see if I can, you guys don't care. CTPA. I mean, it's nothing I'm going to test on. Understanding it goes with PE sometimes. You're not going to be a radiologist. If you're a radiologist, I make you memorize it. All right, CTPA, and this is our study of choice. It requires contrast dye. It's a very high quality study. This is the most common study that's going to be ordered for patients who are evaluating for possible permanent embolism. This one, it's a little more involved. It's an alternate diagnosis. it needs to be considered for these three conditions. I'm sure there are other ones, but I kept it simple. Even patients with renal disease can still get CTPAs. So I'll be very careful when I ask this question, like in which of the following patient populations do we need to consider, right, an alternate way to image these patients. The VQ scan works. It's 2 steps. It's a little bit longer. It's not as sensitive, but it's an alternative. You know, so it's good to rule out, or when you really think they have a PE and you want to confirm it. But you have them use gas to track the ventilation, so you image that first, and then you use a radio-labeled albumin to track the perfusion, and then you overlay them. So it's a little more involved, but it's patients where ruling out a pulmonary embolism is very, very important. And if you can imagine these 3 groups, right? You know, we want to make sure we rule it out, because this person with a contrast allergy may have other comorbidities. Obviously, pregnant people scare everybody, and then again, renal disease. So it is too risky to give this guy IV contrast dye. We're going to put him into, but nobody can figure out why this guy is hypoxic, right? Nobody can figure out. We need to know that, because some patients we don't want to just put them on blood thinners. We have to know for sure whether or not we can take that risk, or we should take that risk. All right, so here's our VQ. So this is the air going in, right? Nice and even, both lungs, and then this lower lobe here is not getting perfused. All right. This is the Wells criteria. I hate this chart because it says that, you know, greater than 4 is PE likely, but you get 3 of those points just if you think an alternate diagnosis isn't likely. So you have to get the whole patient history to make that judgment. So that means anything else it could be, you've ruled out. All right, so we look at things like objective things, which is nice, right? So they have a swollen lower extremity, they've got decreased perfusion, blah, blah, blah. So that gets, so if you see a clinical signs of a DVT, that's 3 points right there. So you only need 1 more point. If a patient has is tachycardic, that gets you almost halfway there. If they're having hemoptysis, if they have history of cancer, and this is where our history comes in, very important. Have you ever had a clot in your leg? Have you had recent surgery? What is that thing? Have you ever had recent surgery? Oh, poor thing. Have you ever had stuck in here? You guys can leave at least. We got to get them out of here. Don't stay in here. Anyway, so this is, so when we look over here, we used to have we do also have a 3-tier where you can say low, moderate, and high. I like the above or below. It simplifies it. So this is the 2-tier approach where if it's greater than 4, PE is likely. If it's 4 or less, PE is unlikely. So we take that, we put it into this chart, you know, so you suspect PE. So if you suspect it, if it's in your differential, then you assess for it. You can use whatever clinical judgment prediction tool that you want. In terms of the Wells being less than or equal to 4, you say PE is unlikely. If it's greater than 4, then you say it's likely. The only difference this is going to make is if it's likely, you're not going to waste your time doing the D-dimer. You're going to do a definitive study. They probably will still get it. But in general, if you suspect it, then you just do the diagnostic study. You've done the screening. And then if you don't really suspect it, then you use the D-dimer to confirm that. I don't really suspect it. D-dimer's negative. I was right. I don't really suspect it. D-dimer's positive. Crap. But crap means then you send them for the CTPA. And then over here I added that so that I didn't confuse you guys. If the patient cannot get a CTPA for allergy reasons, renal disease or pregnancy, then you do the VQ scan. So if the D-dimer is negative, send them home. If it's positive, you get the CTPA then. So that's the only difference. Also, sometimes these dang things aren't inconclusive. I know we said high sensitivity, but sometimes it's inconclusive. It doesn't definitively rule out. That's another indication for that VQ scan, is it can be a secondary test to rule in overlap. Is your question? No? You with your eyes all over the place. Alright. CTPA, too soon. No PE, PE confirmed. Alright. And then over here, obviously, once we have a negative CTPA, in most cases we can discharge the patient saying they don't have a PE. If it's positive, we treat them. Alright, treatment. So stable patients, supportive measures, make sure their sats stay up. So anticoagulation. This is stable. We're not talking about clot busting or anything like that. This is stable patients. We're not needing to emergently reperfuse them. We don't need to do any sort of interventional things where we go bust up a clot somewhere in somebody's lung. Does that happen? Yes. But we're talking about our stable patients who might be a little tachypnic, might be a little tachycardic, and really what we want to do is we want to let that, we just don't want it to get worse. So we thin the rest of their blood out, and then the body then takes care of that clot on its own. And then we just watch them. If the clot's big and it's affecting a whole lobe, they might need oxygen supplementation. Alright, so it does not do this. Heparin followed by warfarin. Okay, so this is Lovenox, so this is a shot. And then we switch over to an oral. And then the goal is, we can overlap these. So do patients go home with Lovenox shots? Yes. But if we can confirm that their INR is at least between 2 and 3 before they're discharged, then we can discharge them just on the oral meds. In today's practice, my dad had a PE. As a DO, I told him he had a rib out, but nope, it was a PE. And he had a PE because he had AFib because he had Graves' disease, which I also missed. And so he had AFib, so he put him on blood thinner, and he's a retired physician, so he stopped taking it, right? Because he knows everything that's going on in his body, and then he had a PE. So, but I was like, yeah, you probably have a rib out, just do these stretches, and no, he had PE. So he went home on Xarelto. The benefit of Xarelto is you don't need to worry about that overlap. So it's much easier to manage. When I grew up, you had a warfarin clinic, you had a Coumadin clinic that was run by a pharmacist, and you had your patients coming in and getting their INR checked and all that. In most places you're going to go now, it's going to be this, these NOACs or these NOACs. So see what you got. I don't want you to be ignorant on this because it still exists, but in most places now, we're going to be putting them on the newer med that doesn't require the check. My dad also had a massive GI bleed after that, so I think that's why he was, before that. So I think that's why he was like dialing back on the DOAC because, the Xarelto, because that freaked him out too, so. That's why I never went into internal medicine. Ugh, it's like, you don't really ever make anybody better, right? You make them better, sort of. All right. FYI, we won't get into this. This is unstable patients. FYI, we won't get into this. This will be an EMED thing. More FYIs, right? All this is really saying is, when we talk about PEs and EMED, when that patient comes in, you need to make that initial determination of whether they're stable or unstable. Additional measures for treatment. So PEs, sometimes they can be recurrent. Sometimes somebody just has a certain medical condition or predisposition or some genetic factor where they have recurrent PEs. And so we can We know that they're coming up through that IVC, we can place a filter. And then this other term, pulmonary embolectomy, this is when we go in and we actually blast that. I saw this done on the show House once. And I was like, crazy, right? And they did it like in a museum room. It was crazy. So anyway, but in general, this is a life saving procedure and has a high mortality associated with it. The other thing I'll say about PE treatment, this was actually a lot of my chronic pain patients. So it's very painful. These are in the mid 2000s, late 2000, 2010-ish, when everybody was on like OxyContin 3 times a day, and then like 6 Percocet throughout the day, maybe a fentanyl patch. It was bad for a while. It was really bad for a while, and I blame Joint Commission for it. But this became one of those pancreatitis and PE. So a lot of my repeat patients in the hospital, they had one PE, and then that was their kind of shoe back in the door to get their pain medications. So they'd come in complaining of symptoms, and their test would be negative, but of course for that first 24 to 48 hours, we'd be giving them lots of pain meds. So, all right, last few topics, pulmonary hypertension. So definition, that means when that mean pulmonary arterial pressure. How do you measure that? You have to drop a catheter to measure that. So over 25 millimeters of mercury. Then you have to do a right heart cath. So the only time you're really going to make that definitive diagnosis is usually, with specialty care. This was something we commonly did in ICU, right? When patients were very, very sick, they had end-stage CHF, maybe they had pneumonia, maybe they had throw a PE in there because they had cancer. So a lot of times we throw a catheter in there so that we could monitor that mean pulmonary arterial pressure and make sure that we were doing interventions that help to maintain that in a same thing we do with blood pressure, right? We want to have it in a zone where it can actually allow that blood to get circulated effectively. If it's too high, then the blood's not going to go where it needs to go. All right. So here's our categories. This is really all I'm going to teach you about pulmonary hypertension. There's not a lot of, so the diagnosis is not a primary care diagnosis. It's usually associated with a very, very sick person. Sometimes, we don't know why, right? That's a lot in medicine. So it actually has some category, it's called group 1. So understanding that this is how we discuss pulmonary hypertension, this is how doctors and PAs and nurse practice communicate by breaking up really what's the underlying cause. And number 1 is, we don't know. Number 2 is left side heart failure. That's the most common. Number 3 is someone has a coexisting chronic lung disorder, right? So where the blood or the circulation's off. Sleep apnea, COPD. So keep those in mind when you're counseling your patients on the importance of quitting smoking or using their CPAP, because pulmonary hypertension is about as bad as heart failure. In terms of once the patient's been in this for a while and we get those hypertrophic changes, not to the left side like systemic hypertension, but to the right side, there's a lot of morbidity and mortality associated with that. And then chronic thromboembolic disease. So placing that the filter. Why do we do that? Because we don't want that to keep happening. All right, symptoms, right? Makes sense, worsening dyspnea. Look for signs of right heart enlargement. So echo, next step in evaluation. Treatment depends on underlying cause, right? Why we care, really, really high mortality associated with it. So we want to make sure we know this exists. We want to make sure it's somewhere in our differential. If we still can't figure out why this person's dyspneic, it's not COPD, it's not, some other cause, right? We get an echo. And then we just want to make sure that if there's things that are causing it that we can stop, that's the importance of identifying this diagnosis. Especially this one because it's got crappy mortality. This term, this is just a term, it means the pulmonary heart, and it simply means the physiologic changes that happen to the right side of the heart as a result of pulmonary hypertension. It is equivalent to left ventricular hypertrophy, but in a different vasculature system. All right, last two. Wegener's, this is the ANCA antibody that attacks the vasculature. It can also affect the renal vasculature, and it causes necrotizing changes. So do we think, so does this make sense? Hemoptysis, right? So it makes sense because it causes necrotic changes to the vasculature. Signs and symptoms, right? So again, it's a systemic disease that attacks the renal and pulmonary tissues and other ones. So chronic sinusitis, otitis, mild fevers. You can get this saddle nose or strawberry gums. These are buzzwords. I'll show you what those look like. So this will go in with the Hereforts and the Lofgrens right at the end. Is that last little, this will give me maybe 1 point on the test, right? Maybe you'll remember for the pants, and that'll be like, oh, thanks, Colonel Cola. All right, chest x-ray. So nodules with cavitations, because again, this is a necrotizing vasculitis. So it's eating away at the tissue. You can do a lab for it, and you can do obviously tissue biopsies to diagnose it. It's a referral. So more than likely, the question will be, if I describe all of this, right? I won't tell you this, but if I describe all of this to you, and you see all these little fun buzzwords in there, then you either have to connect it to this, or you have to connect it to this, right? So that'll be for later. That'll be for when you're not thinking about. Here's some pictures. Here's good postures. This is not the ANCA. This is the GBM. Still affects the kidneys. So I'm sure Colonel Evans is going to be talking about this next semester when we have GU. Then alveolar hemorrhage. There's our hemoptysis again. More common with this good postures. Not really specific chest x-ray. Labs of, you can do labs for it. These are some things that you might see as extra hints. Iron deficiency. Tissue biopsy is obviously just like the Wegener's. Same treatment. A little bit different here, but I will not ask you about treatment, because the treatment, as far as we're concerned, is send them to a specialist. All right. Have fun studying for cardiology.